Hello, I'm Matt Lyon. This is Thoracic Ultrasound. Our learning objectives are to describe how to perform thoracic ultrasound, to cite the indications for the use of thoracic ultrasound, and to correlate findings from ultrasound to findings on chest X-ray and CT images. We'd also like to use thoracic ultrasound to eliminate differential diagnoses and case presentations. The first part of this lecture is going to focus on the technique for thoracic ultrasound, a systematic approach for thoracic ultrasound, the sliding lung sign, and detection of pleural effusions. So thoracic ultrasound is something new to most people. This is because ultrasound has been thought to not be useful in the thoracic cavity. The enemies of ultrasound are bone, air, and distance. Hence, since the lungs are filled with air and covered by bones or ribs, many people think that ultrasound can't be used for the lungs. The opposite is true though. Normal lungs tell you a lot about your patient, and abnormal lungs can be seen using ultrasound. So for this lecture, we're going to use a case-based presentation to demonstrate how to use thoracic ultrasound. We're going to learn about pneumothorax, the diagnosis of pneumonia, interstitial edema, atelectasis, and lung abscesses using thoracic ultrasound. So for thoracic ultrasound, we can use a variety of ultrasound transducers. Most ultrasound machines have at least 2, if not 3. And I generally use all 3 of the ones you can find on most ultrasound machines. The linear transducer is the one that was traditionally described for thoracic ultrasound. It is a high frequency probe and gives very high detailed resolution images because of this high frequency. Generally, I use this for pleural evaluation, which we'll cover in the last part of this lecture. The curvilinear probe, which is used for the abdomen, is another probe that can be used for thoracic ultrasound. It's a good probe. It's a lower frequency probe, but it does give a lot of detailed information also. The phased array probe is a high contrast probe. It is meant to get between the ribs, so it does not image the pleura very well. It does image the lung parenchyma very well, and as such, it is one of my favorite probes to use. Our choice of transducer depends on what we're trying to image. As with all ultrasound exams, you must have a systematic method for use of the ultrasound for making your diagnosis. This is going to be divided into key concepts. The first key concept is we must place our probe across the ribs. We do this for a variety of reasons, but in ultrasound, you must be able to identify something so that you can identify everything else around it. And when we put our probe across the ribs, as we see here, we can identify the rib. Once we identify the rib, we can identify the pleura. The pleura is always just deep to the rib, and it is always easily seen in this cross-sectional image of the rib. If you had your probe turned long to the ribs and could not see them, you would not be able to tell which layer was the pleural layer, particularly when the lungs are abnormal. Once we've identified the rib in cross-section and then identified the pleura, we look for movement of the pleura. This movement can be seen as a fine undulation between the 2 pleural surfaces. We must remember that the 2 pleural surfaces are normally opposed one to another, as we can see in the CT scan. When we look in the CT scan, the visceral and parietal pleura are up against each other. Therefore, you cannot distinguish one from another. In the ultrasound, it is the same situation. The 2 pleura are very thin layers, and they are one against another, so you can only see them as a single line. However, as we turn down the gain as we have here, you can see that those 2 pleural surfaces are moving relative to one another. That is because the parietal pleura is fixed to the chest wall, and the visceral pleura is sliding with lung inspiration and exhalation. This is called the sliding lung sign, where the 2 pleura are moving one against each other. And it's very easy to see when you turn down the gain, and you can see just the pleura deep to the ribs. In this case, we're using a curvilinear abdominal probe, and it provides a fine detail of the pleural surface. Now, where we scan to look for various pathologies is an important concept. And it makes a big difference in when we're trying to be accurate with our thoracic ultrasound. If we're looking for a pneumothorax, we must have the patient supine. and then we scan the anterior chest because the pneumothorax, or the air in the outside the lungs, will rise anteriorly to the most superior portion of the chest. If we were standing up, that would be under the clavicles and we would not be able to see it. If we're lying flat, that will be the anterior chest wall near the nipples and will be easy to see. We'll cover this in a few minutes. For a pleural effusion, I like for the fluid to collect in the bases, and I want it to be the largest collection possible. Therefore, I usually have the patient sitting semi-erect, and I look at the costophrenic angle, which is the lowest, most dependent portion of the chest cavity. If I'm looking for interstitial edema or pneumonia or PE, I'm going to scan the whole chest, and I'm going to correlate what I find to the body position that they are in currently and have been before the exam. This will become more evident in the second part of the lecture. Here we are, we're doing a typical scan. The patient is sitting. Most of the patients I scan are ambulatory. And since they're ambulatory, I keep them in an ambulatory position for the most part. I scan generally to find something that I know. Again, I'm looking for the ribs, but I also want to look for the liver or the spleen because those are landmarks for me. Once I identify the liver or the spleen, I look for the diaphragm. Once I've identified the diaphragm, as you can see here, I slide up the body, looking at each interspace between the ribs. I don't really care about the ribs themselves, except that they are my markers for the pleural space. What I'm doing is looking at the pleura and deep to the pleura. We will cover this more a little later in the lecture. One of the misconceptions about ultrasound is how to scan and where to scan. These three images you see here are from journal articles, and they divide the chest into many sections. I don't necessarily do this, and you will see how I do it in the second part of the lecture. What you need to know is that where you find an artifact or a pathologic finding will depend not only on where the patient is currently, but where they have been. So if your patient has been ambulatory and comes in with a cough, you will be looking for the artifacts that indicate pathology in a different location than if the patient had been laying flat in an ICU bed for the last week. Many pathological entities will depend on this positioning. For example, if you had CHF and you had been ambulatory, you would expect to find fluid or rails on your physical exam at the bases, and it gets less as you move up the chest. If you had been lying flat for the last several days, you would expect to find it towards the back, and it would become less as you come towards the anterior chest. This is true with ultrasound also, and we shall talk about this more in the future. The key here is to remember that when you read a journal article, they may not have been paying attention to this fact, and their sensitivities and specificities may not be as accurate as they could have been if they had followed some systematic approach that takes into account the patient's body position before the ultrasound scan. Now, I am teaching you ultrasound based on my experience. Most of my patients are ambulatory before I scan them. Therefore, I look for ultrasound artifacts in dependent locations in the upright person. If your scanning typically involves non-ambulatory patients, you may have to look in a little bit different location than where I normally look. But we'll cover these as we talk about each of the entities we're covering. Let's go to a case. A 34-year-old male comes in with acute shortness of breath. He has no history of trauma. It started suddenly, and he's got left-sided chest pain. How do we want to use thoracic ultrasound to help with the differential diagnosis? Let's look at his ultrasound. So here's his ultrasound. We put our probe across the ribs, and as such, we can identify the ribs. Just deep to the ribs, we see a pleural line, which is a hyperechoic line you can see here. Then we want to look at the pleural line itself and see if it has motion. The person is breathing, and so that pleural line is moving up and down. But if you look carefully, there's no relative movement of the pleural line. The pleural line is not moving horizontally as if two pleural lines were opposed one another. So let's remember what a normal pleural line looks like. So in the normal thoracic ultrasound, we can see the two pleural lines is moving one against each other. And so there is a movement at the pleural line. In the patient's ultrasound, we don't see that sliding of the two pleural surfaces one against each other. In the normal thoracic ultrasound, this is called the sliding lung sign. In the patient's ultrasound, we do not see this sliding lung sign. So when you don't see a sliding lung sign, you have to think that there's something in between the two pleural surfaces which prevents you from seeing the deeper or visceral pleura. In this case, it's air. And air is our enemy. It is the enemy of ultrasound, and we cannot see through air. So as seen on the CT here, if we scan through the pneumothorax, we see the parietal pleura, then the air interface. Therefore, we only see one pleural line. Since we only see one pleural line, we cannot see the sliding of the visceral and the parietal pleura one against each other. The sliding lung sign is fairly specific and sensitive for pneumothorax. Several studies have shown it to be between 95 and 100% sensitive and up to 100% specific. If you add something called the lung point, the specificity goes to 100%. We'll talk about that in just a second. So let's talk about the sliding lung sign for pneumothorax. For this exam, the patient must be supine. They must be bored flat. Think about a patient coming in on a long spine board. They are bored flat. Their head is not elevated and their chest is not elevated. If you did have an elevation of their head, neck, or chest, the air may move from a place where you can image it on the anterior surface of the chest up under the clavicles where we cannot image it. So for pneumothorax, we want to have the patient bored flat. Then we want to evaluate the most anterior portion of the chest. Generally, this is going to be the third, fourth, or fifth intercostal space. What I do is I start about the nipple line. I check for sliding on each side. Then I move up or down a rib or two. Therefore, I know that there is no loss of sliding lung sign anywhere on the anterior surface of the chest wall. So let's look here. Here we have a thoracic ultrasound and we can see the pleural surface. In the bottom picture, it is very difficult to see the pleural surface because it's fairly bright and it's fairly low resolution. The top picture is the same person and you can tell the difference in resolution. It uses a linear probe, and as I said before, it uses a higher frequency, so it's higher resolution. And you can see the little tiny black dots on the pleural surface are not moving along the pleural surface. Now, after you get a little bit better at looking for the sliding lung sign, you can use the curvilinear abdominal probe as we see on the bottom, which has less resolution. And you won't need to use the linear or higher frequency probe to see this sliding. But when you're learning, using the high frequency probe can be an aid to you to make you have confidence that there is no sliding lung sign or a pneumothorax present. You can use something called M mode. Remember, M mode shows motion of something over time. In this case, we've put our probe across the ribs and our M mode line in between the ribs. As we come down the ribs, we see the motion over this line over time. The line initially is going through the chest wall, and the chest wall itself is not moving over time, so it produces horizontal lines. As we reach the pleura is moving relative to one another, with the lungs moving in and out with respirations. This causes a very bright line at the pleural line, and then below it we see static or sand. This is called the seashore sign because it looks like waves coming into a sandy beach. If we look at the one below, this is a patient with a pneumothorax. We see the same chest wall horizontal stripes, but as we reach the pleural line, which is very bright, we do not see the deeper pleural surface or the lungs below. Therefore, we get these horizontal lines. This just looks like waves coming into waves. No waves coming into sandy beach. This is called the stratosphere sign or the barcode sign, and it is indicative of a pneumothorax. So here's an example. We have our probe across the ribs. We've placed our M mode line through the lungs, and we see waves coming into the sandy beach. The other artifact you see is the heart. And if you can see the heart, there is not air between your probe and the heart. Therefore, there is no pneumothorax. One more time. Here's our probe through the pleural surface, and we can see the waves coming into the sandy beach, so this is not a pneumothorax. Here, we look at the pleural surface, and it appears that there is no sliding. So we put our M-mode line through there, and we do not see any sandy beach. We just see waves. It looks very much like that barcode sign we were talking about before, and this is what a pneumothorax looks like on M-mode. One more time. We have our probe across the ribs, place our M-mode line through the pleural surface, and we watch how it occurs. Here we have just horizontal lines. This is called the barcode sign or pneumothorax. If we look here, we can see a sliding lung sign. This is my most favorite technique for doing this. I turn the gain way down. When you turn the gain down, everything gets dark, but because the pleural line is so echogenic, it stays bright. And then your eyes can focus just on the pleural line, and you can see that motion side to side. It's very easy to see. This is the sliding lung sign, so therefore this patient does not have a pneumothorax. So what is a lung point? The lung point is the point where the pneumothorax ends and normal sliding is seen. This is the apex of the pneumothorax, or where the pneumothorax ends and the two pleural surfaces begin touching each other again. This is 100% diagnostic for a pneumothorax. It also allows for grading of a pneumothorax because as the pneumothorax gets bigger, you can track the lung point around the chest wall. If you find the lung point in the anterior axillary line, it would be a small pneumothorax. If it's towards the posterior axillary line, that would be a moderate pneumothorax. If you have to go closer to the spine or you can't find it all, then it's probably a large pneumothorax. You can see here on this picture, you can see where the pleural surfaces begin touching one another. This is where the lung point would be seen. But because we use ultrasound and we can see things in dynamic motion, the lung point will look like it moves. So you can see here where we placed our transducer on the lateral chest wall. We're imaging the point where the pleural surfaces are touching and where the pleural surfaces are separated by air. And because the lungs are moving in and out with air, that point will move up and down the chest wall. And that's what we see here on the image on the left. We can see the lung sliding, we can see that pleural sliding, and just at the edge we can see where it stops. If we go the next rib space, we can see there is no sliding. This is the lung point. This is where the pneumothorax ends and the normal pleura are touching each other once again. So let's go back to our case. A 34-year-old with acute chest pain and shortness of breath. The patient's thoracic ultrasound is below. If you thought this was a pneumothorax, you're probably correct because we don't see any sliding of the pleural surface. But how would you confirm this? You're correct. You'd look for the lung point. So here we are, we're looking for the lung point. We think we see it. We use M mode, and what we see is waves coming in the sandy beach, and then we see loss of waves. Waves coming in the sandy beach, and then loss of waves. There's something here that looks a little different than the image I showed you before. And it's a big, dark area. We call that in ultrasound hypoechoic. So we have a big hypoechoic area. We've been looking for air. Air, we can't see anything. We cannot see through an air interface. It is one of our enemies to ultrasound. One of our friends for ultrasound, though, is fluid. This is fluid. Fluid is hypoechoic, and in this case, it's in the thoracic cavity, therefore it's a pleural effusion. Ultrasound is highly sensitive for the diagnosis of pleural effusion and can detect as little as 100 milliliters of fluid. Because it is fluid, it will generally collect in the most dependent portion of the chest. Therefore, patient position is very critical to detecting a pleural effusion. Pleural effusions generally have regular borders. So you can see the smooth border of the diaphragm, the smooth border of the pleura, and then you can see the lung that is being compressed by the fluid. It looks like it is floating in the breeze, but really the black is fluid, so it's lungs floating in fluid. So again, if I'm looking for a pleural effusion, if I'm looking to say, is there a pleural effusion, yes or no, I scan the patient in the recumbent position, and I look most laterally near the costophrenic angle. So I put the probe in the flank, either the right or the left, and I look for the kidney and the spleen or the liver. Once I've identified the kidney and the spleen, I look superior towards the head and I identify the diaphragm. Once I've identified the diaphragm, I look for the spine, which is posterior to the kidney. When I identified the kidney, the diaphragm, and the spine, I know that I'm looking at the most dependent portion of the thoracic cavity. If there is no pleural effusion there, then the patient does not have a pleural effusion. Once I've determined that the patient has a pleural effusion, then I sit them up. When I sit them up, I look again for the liver or the spleen, then the diaphragm. Then I know everything above the diaphragm is the thoracic cavity. And I also know that if I see black fluid above the diaphragm, that's the pleural effusion. Then I can walk my probe up the back to see when the normal lungs appear again and the black hypoechoic fluid is no longer present. Here on this picture we can see a large stripe of hypoechoic black fluid. We're using M mode, so you can see the movement of the lungs over time, which are deep into the chest. They're being compressed by the fluid so you can see the lungs, that is lung tissue. It also tells us the depth from the skin or the probe down to the lungs. Here we have 7.3 centimeters from the skin to the bottom of the screen. The lungs are at about 6 centimeters. So I know if I use a needle less than 6 centimeters, I will not hit the lungs with my needle and cause a pneumothorax. You can also guesstimate the amount of fluid present in the pleural effusion by looking at the depth of the fluid and how far it tracks up the back. I'm not really going to cover this because it's a little bit of a guesstimation, and with experience you can tell whether this is a small, moderate, or large pleural effusion by how far it tracks up the back. A pleural effusion could be complex or it can be simple. By that I mean that it can be a transudate or an exudate. Typically when we're talking about fluid diagnosed with ultrasound, we talk about it as being simple or complex. Simple being completely black fluid, and complex fluid being fluid that has echogenic particles or echogenic structures in the fluid. Unfortunately, you cannot tell the difference between a transudate and an exudate if it's just a simple pleural effusion, because a simple pleural effusion could be an exudate. However, as we can see in this picture, there's lots of stuff or echogenic particles floating in the pleural effusion, and therefore we know it has to be an exudate. This is an empyema, and this is pus that is coalesced, and we can see it with ultrasound. Occasionally we will see other types of pleural effusion. In this case we see a pleural effusion which would be called caseous. It is fairly thick. It has multiple hypoechoic areas in the hyperechoic fluid, and this is consistent with tuberculosis. Tuberculosis is characterized by caseous pleural effusions, and if you're in an endemic area and you see a caseous pleural effusion, most likely it will be TB. This is the end of part 1.